Okay, hi there. We're back again. So now if you have my notes or my syllabus, I follow my syllabus very closely. I want to talk about another construct. And earlier I did mention that perception is very important. Uh, Perception is important for anything and everything in life, but especially in regard to fluency disorders. And so, think about what is perception? Is it the speaker who's doing the perceiving, or is it the listener who's doing the perceiving? Well, most of the time we're thinking about the listener. I perceive that she's a very nice person, or I perceive that she's a very fluent person. So, when you're working with someone, excuse me, with a fluency disorder, uh, think about maybe a 2x2 matrix. And I wish I had on my blackboard here. I'm in a recording studio. But, draw a 2x2 matrix and think about the reason it's 2x2 is that the two options for each dimension is whether one of the two is I am stuttering versus the second of the two is I am not a stutterer. And the same thing with this dimension. I am a stutterer, I am not a stutterer. Well, the point here is that it's great when the perceiver, the listener, agrees with the speaker. In other words, if the person who used to stutter feels that, she's very fluent now, she wouldn't even call herself a stutterer anymore, it's great if that's her judgment or perception, and it also agrees with the clinician or the listener's judgment or perception. The problem is that this doesn't always happen. Can you imagine that? So, can you imagine yourself as a clinician in the situation whereby you are ready to dismiss your client? You've been working with a stutterer for 3 years, and you don't perceive, you don't hear any disfluencies, any stutters, okay? And you say, Barbara, you've done so well, you've made such improvement that I'm ready to dismiss you because I don't think you stutter anymore. To your surprise, Barbara says, I still consider myself a stutterer. Okay, can that ever happen? Okay, that there is a disagreement or contradiction between the perception by the speaker, your client, and your perception. Yes, it happens. It can happen. And what might account for that? Okay, if you were in front of me, we can have a discussion, but you can have a discussion with yourself. Okay, think about that. How can that ever happen? Well, one possibility is that the person could sound fluent, but there may be some, if you will, subclinical anomalies going on that only the speaker can detect. And those anomalies, frankly, have to do with subclinical, that is, not apparent to the outsider, subclinical signs or symptoms within the person that I am still tense. I still have muscular tension. I still feel not very coordinated in my speech. Okay? Now, I often use analogies from everyday life so that students can relate to this. So, have you ever felt very tense inside? And let's say that you have to give a presentation, and you just feel like, oh my gosh, I'm just doing an awful job, and I'm just so tense inside. And after you finish giving your presentation, your friends say, good job, that was really great. Okay? They did not perceive, they could not detect, it was subclinical, the tension that you were going through. Okay? So that's an example of where clinician thinks that the client is fluent, yet the client doesn't feel very fluent. Okay? So my question to you then is to think about is, which is more valid? Which is more valid? Which perception is more valid? Your client's perception or the clinician's perception? Which is reality? Is it the clinician's reality in terms of what she sees and hears, or is it the reality of the speaker for the stutterer? Okay. What do you think? And if someone could be my little secretary here, maybe when we meet as a class, would you jot down some of these questions that we can discuss in class? I know earlier I had asked you to think about the Parkinson's versus dysarthria, apraxia. So would somebody remind me to have a little discussion about the validity of perception? After all, clinicians just went through 60 credits, so she's the expert, right? Well, maybe, maybe not. It's an issue we can discuss. Okay. Another possibility that may feed into this discrepancy between client and clinician is that the clinician is not with the client 24 hours a day. So the clinician can only sample behaviors that are primarily within the clinical setting. The clinician does not see the client out in the real world. And this is why I am asking you for your final project to do 2 fluency samples, because one sample is not sufficient ever, ever, ever. You really need multiple samples because fluency varies for a stutterer depending on the pragmatic context. Okay, so and so therefore, the clinician may not see the client in a stressful situation or talking with 10 people. In fact, most of my clients say that, when I'm with a clinician, I'm very, very fluent. And so is it right for us to think about the client's diagnosis and fluency, degree of fluency, just based on our one-on-one interaction? I think not. On the other hand, we have our good old clutterer, okay, who most of the time will deny that they have a problem. So I'd even say that when I was introducing cluttering to you earlier. Besides the fact that even if they are aware, they don't self-monitor, but they actually deny that they have a problem. And you're saying to yourself, how could anybody deny that she has a problem when you can't understand them, their speech is unintelligible, their narratives are not very coherent? Well, they will deny till they turn blue in their face that it's not their problem, it's the listener's problem. In fact, if we have time, you will see a DVD that the Stuttering Foundation commissioned, and on the morning of the taping, Nina, the girl who's in the DVD, told me as we were setting up the props and everything that, Dr. Myers, I don't talk too fast. You just have to listen faster. Okay. So, obviously there's a discrepancy in perception there. All right. So now, The next major item on your syllabus and in your notes is the so-called three-factor model by Myers and Wall. And this came from an earlier book that I co-authored called Childhood Stuttering and Clinical Procedures of Childhood Stuttering. And at that time when I was writing it, I was very much influenced, because I had to teach myself Bloom and Leahy. So I was very much influenced by the three-factor Venn diagram model. And so I decided to apply that Venn diagram to stuttering. And so if you could draw three circles that intersect, as in Venn diagrams, and label one of the circles in the Venn diagram as psychosocial, the second circle as physiological, and the third circle as psycholinguistic. So this is the three factors: psycholinguistic, psychosocial, and physiological factors. And basically what I do, this is going to frame our entire course, both the knowledge base of this course, as well as assessment, as well as treatment. And in fact, feel free to use this three-factor model for clinic as well, because I use these three factors and this Venn diagram for assessment and treatment. And what I do is, for each of these factors, I have on the side of each circle, I would have a line and say, well, this client has an asset, and I put a plus there, an asset in one of the factors. Let us say if we were talking about psychosocial. Well, this child's asset is that this child has a very good sense of self-esteem. That's definitely an asset, okay? But maybe after interviewing the parents and, working with the child, I realized that a potential liability, and so I put a minus for liability, is that, even though this child has a very good self-esteem, it appears to me that this child has very demanding parents. And that's an aspect of psychosocial. Okay? Parents with very high standards, academic standards, athletic standards for this child. Okay? So, whereas, this three-factor model can serve as a framework for your knowledge base, but also I would encourage you to use it for clinical purposes, both assessment and treatment. And of course, any Venn diagram also has intersections, that is, overlaps between one factor and another factor. So an example of this overlap is, let's say, between psychosocial and psycholinguistic. So a good area of overlap is pragmatics. Pragmatics is both an aspect of language or communication, and it's also, of course, an aspect of the child's psychosocial arena. So, with that as a framework to work from, let's now talk about the knowledge base for psycholinguistic factor. And I'm going to now review with you some research findings, because there should be continuity between what's in the journals, from research to therapy. That's why we call therapy now evidence-based therapy. It's based on research, okay? So, research has found that the height of stuttering onset often is during language development period. Okay? And if you think about that, it makes entire sense. After all, what is the foundation for language development when you were 2 and 3? Well, your cognitive development, your perceptual development, your social development, your emotional development. And so everything is developing at the same time. And obviously, when things are in development, they have not stabilized. There is some volatility in the system. Okay? And the analogy here for you, so that you can relate to this, is that when you were developing your skiing skills, it's likely that you fell from time to time. You had a snow plow. You were awkward, you were discoordinated, you were, just had a lot of glitches as you were coming down the hill. Okay? Well, in fact, those bumps, if you will, or those glitches are very much analogous to the disfluencies of the preschooler. And that is why the height of stuttering occurs during this very, very fertile and yet volatile dynamic period. It is very important for you to try to understand that so that you, in turn, can explain this to parents and teachers. Why? Because there's a large proportion of children who have developmental disfluencies and perhaps even developmental stuttering. But the good news is that, and later on we will talk about this, the good news is that there's a high rate of what we call spontaneous remission. Anywhere between 40 to 80% of spontaneous remission for children who have been diagnosed as stutterers. Okay? Now, that's the good news. But the not so good news is that you don't know for a given child and a given family whether this child is going to have spontaneous remission. So do you just let it go? And the analogy here is medicine as well. If you have some, if you will, irregular cells that are not quite cancer cells yet, it may just go away or it may sort itself out. Do you let it go or do you try to treat it? Treat it at least in terms of lifestyle. Because we don't know, whether it's going to aggravate and become more severe in time or stay status quo or actually dissipate. The other thing is, just like illnesses, where if this happens to you, you get very, very stressed about it and very, very nervous and tense about it and worried. Well, of course, families of children who show stuttering become very, very, very worried about their child. And you can't just dismiss this child by saying, well, there's a high rate of spontaneous remission, because you don't know whether this child will have that or not. Okay? Research has also found that there is a strong link between fluency and language dysfunctions or functions. Recall that earlier I said when I introduced the course that really fluency is a suprasegmental. Okay? It's an envelope that governs everything you do and not do as you're talking. Okay? So if your language functions are well formed, it's likely that you will be fluent. However, if your language functions are still developing, or if your language functions are not well-formed, if you will, then you're going to have disfluencies. A purely language-based set of disfluencies will be what we call the maze behaviors, the linguistic maze behaviors, like the fillers and the revisions. Okay? So, here yet again, we're talking about the fact that our preschoolers are developing speech and language, cognitive, perceptual skills, even motor skills, that's required for speech, social skills, everything. And so therefore it's not surprising that there's going to be a strong linkage between the child's fluency and speech and language during those years. Just to cite a very, very compelling example of this, even with typically developing children, there's a study by Colburn. Her mentor was Lois Bloom at Columbia University. And so she actually borrowed Bloom's tapes. Back then people used tapes, the transcriptions for those 3 children. Now bear in mind, those Bloom and Leahy form content categories are based on normal development, not language disordered children. Okay, so these are normal kids. And the bottom line is that she found that there was a rise in disfluencies as a particular content category was being acquired. Okay, note my verbs here. As it was being acquired. As it was being acquired. So in the process of being acquired. Then once a content category has been mastered, there was a decline in disfluencies. Okay, so this happens even with normal kids. And, if the parents that you're talking with don't understand Bloom and Leahy content categories, well, you could use an everyday example such as a child learning how to ride a bike. Okay, as the child is learning how to ride a bike, she will teeter-totter, maybe fall a little bit. Those are the bumps of speech or disfluencies. And then once the child acquires and masters the bike riding, well, everything is nice and smooth, and it's beautiful. So I guess one thing to keep in mind is that when you apply this knowledge to clinic, and especially if you're talking with the clients themselves, but especially with children, the parents, give them these everyday analogies so that they understand. And in fact, this is what I am doing with a family who has a child who stutters at times, and I have to use these analogies so that they understand. Understanding is so important for the family, but also for the client, so that they would understand your rationale once you apply therapy goals and techniques with your clients. So that was Colburn's study. And so since we're doing evidence-based therapy, what is the evidence we found through research is that there's a strong linkage between language and fluency. And therefore, what's a possible implication of this for therapy? Using Bloom and Leahy. Well, if, let's say, you find that your child is developing at level 5, phase 5 of Bloom and Leahy, okay, then the language demands that you make on the child during fluency therapy, you may want to downgrade the language demand. So if the child is at phase 5, maybe work with utterances that are at phase 3 or 4. In layman's terms, it's simplifying the language. You don't want to give the child a double whammy. That is, you are expecting good fluency, but you're also expecting their max in terms of language. Okay, so downgrade language as you work on fluency. That's very important. Research has also found that about 1/3 of children who stutter have other language and speech issues. Okay, and so you must be aware of that. We use the term comorbidity or co-occurrence for this phenomenon where, the same child can have both language problems as well as fluency problems, outright disorders. Okay, so it's co-occurrence, comorbidity. Okay, lesson number 1 clinically is that you're going to treat a child who's a pure stutterer quite differently from the child who has both a fluency problem as well as a language problem. Okay. Now, you don't even have to have a language disorder, because even the child whose language advanced can show disfluencies. And that should make sense by now, because if your language advanced, where does the language come from but thinking cognitively? Your cognition. So if the precocious child may also show disfluencies, the language advanced child may have also disfluencies, if not also stuttering. So that's the idea of co-occurrence, comorbidity, and third word is concomitance. All right, so still talking about the psycholinguistic factor, let us talk about some evidence from research that specifically focuses on syntactic influence. That is, can syntax influence fluency? Yes, it can. Research has found that children who stutter, so would you correct my notes, please? It's not CWC, but CWS. Children who stutter are more likely to stutter at the beginning of clauses. Okay, so the child may say, "We went to the zoo and we saw a tiger and we saw an elephant and then we went to the aviary." Okay, so at the beginning of clauses or phrases, people hypothesize that the reason the disfluency, the stuttering, occurs at the beginning of clauses is that it is precisely at that juncture, at the beginning of clauses, that the child is planning what to say next. Okay. We also know that children who stutter are more disfluent on sentences with more complex syntax. Okay. So sentence complexity has a greater impact on stuttering than sentence length. Okay, here's an example. If I'm going to use a sentence such as, "Even though it's going to snow next week, we're still going to have class through Moodle." That's a complex sentence. comprised of one dependent clause and one independent clause. Okay. And I didn't count the actual number of words, but let's say it had 15 words in the whole sentence. As opposed to the following. We went to the zoo and we saw an elephant and we saw a zebra and we saw birds and we saw a tiger, and then we went home, we went to grandma's. That sentence, let's say, had 25 words. Okay? But that second sentence is syntactically easier than the first one because it was just a string of simple sentences linked by and, as opposed to the first sentence, which was a complex sentence comprised of a dependent clause and an independent clause. Point here is that your stutterers are going to be more disfluent on syntactically more complex sentences. Okay? So obviously, therapy implication here is that you start out with simple sentences. Don't have the child read or speak using complex sentences. In fact, perhaps even start with phrases or start with just words. Okay, you want to build up. You don't want to burden the child or adult. Another piece of evidence which will have therapy implications, so, even though we're not talking about therapy yet, everything I talk about has clinical implications, therapy implications. So research has also found that if you have a child imitate a sentence, that's likely to produce less disfluencies than if you use the therapy technique of sentence modeling. Sentence imitation is, okay, I want you to say, repeat after me, it is snowing, it is snowing, it is sunny, it is sunny. Okay, that's straight imitation. Modeling is when you give the child the following. Say, I'm going to say a few sentences, and you listen to the pattern of my model. And then you make up your own sentence following my modeling. She is swinging, she is eating, she is sleeping. Can you say your own sentence? And the child says, she is napping. Good. That was modeling. Okay? So again, modeling is likely to produce more disfluencies for a stutterer than sentence imitation. Therapy implication then is you start with imitation in therapy. Research has also found that school-age children and adults stutter more on the following, namely, content words, and in this context, content words are distinguished from function words. So content words are the words that really convey a lot of information, like nouns, verbs, adjectives, adverbs, as opposed to function words like prepositions at, a, or articles, a, the. They're also likely to stutter more on longer words, and as I said earlier, words at the beginning of utterances. So that gives you a good idea, and I hope I can convince you that there are syntactic influences on stutterers' fluency behaviors. Okay. Now, what about semantic influences? Very interestingly, there is a idea or construct, and I've pardoned for the typo there for construct. These were my notes, and so I didn't edit them. Construct or idea of propositionality. Propositionality. Propositionality has to do with the degree of information load or emotionality of an utterance. Okay, So an example of information load, high information load, is if I were to say, okay, Johnny, I want you to tell me how you get from here to Hofstra. That's a lot of information there to convey. It has to be accurate. Okay, as opposed to if I were to ask John to say, okay, what is your last name? That's in a way low information load because he knows his name. Okay, emotionality, low emotionality is what is your name? High emotionality is why were you late to class? Okay, because if I asked you that in a confronting way, I'm putting you on the defensive, and you did something wrong, so to speak, and you have to respond. So here the idea is that the higher the propositionality level, the greater likelihood of stuttering. Again, this has therapy implications. You're going to start out with low propositionality levels and then work your way up while you maintain the client's fluency. We also know that some of our clients, and including some people who stutter, because there is comorbidity, that clients who have word retrieval issues will have more disfluencies and stuttering sometimes. So this includes children with LD or adults with learning disabilities, aphasics, and even you and I sometimes have word retrieval issues. Okay, so that's another link specifically related to semantics that can influence fluency. So please, you need to be very sensitive to the child with semantic issues if you're working also with their fluency. Next is the influence of pragmatics. I said earlier that this, pragmatics might be where there's the overlap between psychosocial and psycholinguistic, because pragmatics is both, okay, in the three circle Venn diagram. Okay, so research has found that not only for children but even for adults, that there are more disfluencies when the discourse, so now we are talking about pragmatics, when the conversation or discourse is more disruptive, stressful, or rushed. Okay, disruptive. Okay, are there households that are very disruptive, stressful, or rushed? And here, whoever is jotting down some questions for discussion in class, would you remind me to ask the class and discuss when we get together, reflecting on your own household when you were growing up, on a rating scale 0 to 5, 5 being max. Was it, in your opinion, disruptive, stressful, and rushed, or not? Did that have an impact on you when you were growing up? And even now, does it have an impact on you? Okay, so for example, one piece of research found that children who had to change the mother's pragmatic intent or agenda showed more stuttering. And that's because whenever you change your mom's agenda, like how was school today, how did you do on the test or the quiz, and you don't want to talk about it, and you want to change the subject, you have to be more assertive. And I think that pragmatic intent of being more assertive can result in more stuttering for the child. Okay, so let me see where we are now. as you can see, and are you there?
Hi.
Come on in. Okay.
Oh.
Hi.
Hi.
Okay. Then a very, very important area is that, we've been talking mostly about verbal behaviors, but what about the nonverbal behaviors of parents? Okay. By not thinking that you're not saying anything, you're still conveying a lot. And in fact, I feel that your nonverbals speak more loudly than your words, than your verbs. Your verbs, I'm getting tired now. Your words. And we can discuss that too when we meet. So basically, the one study was they videotaped mother-child dyads, and the mothers were of both. One set of mothers had children who stuttered, and one set of mothers were children who did not stutter. And as you know, whether you stutter or not, you have disfluencies. And the bottom line finding was that both groups of mothers, tended to interrupt their children more when they were disfluent. And if you ask any stutterer, being disrupted is really a no-no. They don't like that. And especially if you interrupt them and then finish their sentence for them. Okay? So, what are the therapy implications of that finding? Well, counsel your parents not to interrupt them. Counsel your parents to give their child time and space to talk, even if they have to go through and struggle through a block, a stutter. Okay? Because if you give them time and space, that will give them the leisure, or at least some ability to motor plan and to linguistically plan what they want to say. And most importantly, they realize that their audience, that is their parents or whoever else, the teacher, is very much willing to wait until they finish their word or sentence. Okay? So that then actually concludes the section on psycholinguistic, the first factor of the Myers and Wall three-factor model. And when we resume, whether in vivo or what do you call it? In virtual reality, we'll pick up on psychosocial factor. And please, would somebody or one or two people pull out the questions that I asked you to do so that we can have class discussion when we meet.